Good evening, everyone. My name is Ashley Tucker, and I will be moderating this evening's webinar. Welcome, Dr. Stephanie Tran, who will be giving us a wonderful talk on to surgery or to scleral. Dr. Tran graduated from UC Berkeley School of Optometry and completed her residency in cornea and contact lens and ocular disease at The Ohio State University. She also holds a graduate degree in biomedical engineering, for which she pursued extensive research in corneal collagen structure and organization in keratoconus eyes, as well as corneal wound healing. Dr. Tran is a fellow of the American Academy of Optometry and also the Scleral Lens Education Society. She currently practices in Orange County, California, in an OD-MD practice at Coastal Vision Medical Group with her corneal specialist father and founder. There, she supports corneal surgeons in pre- and post-operative care, management of anterior segment disease, and advanced scleral and specialty lens fittings. Dr. Tran continues to stay involved in clinical research in scleral lenses, cataract, and refractive surgery. Outside of practice, Dr. Tran enjoys running, hiking, and playing golf. These are Dr. Tran's her financial disclosures. They have all been mitigated. Just a couple housekeeping things about our webinar this evening. As always, please feel free to put any questions in the Q&A feature or the chat feature. I will be monitoring them, and I will ask those questions to Dr. Tran at the end of the webinar. In order to receive CE credit, you must remain online for a minimum of 15 minutes for COPE credit. Attendees are welcome, but absolutely not obligated to stay on for the Q&A. Course handouts will be found on our website shortly after the webinar is completed. This is new, so if you have not been on any of our webinars, hopefully you have been, but if you haven't so far this year, you will be able to get your CE credit immediately, or you'll be able to see that you get CE credit immediately if you download the OE Tracker app in the Apple Store or Google Play Store. After the CE session, you have to do it after. Open the app, verify your personal information is correct, and then touch scan QR code, and your camera will open immediately. Scan the QR code that I will show you at the end, and then a confirmation will appear if correctly scanned. It's okay if you have technical difficulties with this. We will still be emailing your certificates within 2 weeks. All right, that is it for now. I will unshare, and Dr. Tran, it is all yours.
All right. Okay, can you see my screen there? Oh, okay. So thanks, Ashley, for the introduction, and thanks everyone for tuning in tonight. I hope you're all doing well with the daylight savings. It's pretty dark already, and I'm in California, so we'll get through this together. Tonight we're going to talk about to surgery or to scleral, and some of let me just move this here real quick. Some of the topics that we're going to talk about are going to be whether a patient's going to benefit from surgery, a medical surgery or refractive surgery, or scleral lenses. And we're going to talk about the optimal timing for fitting these patients in scleral lenses if they are going to have surgery or a corneal cross-linking procedure, as well as how to manage these patients post-surgically with scleral lenses. We're also going to talk about fitting concepts and a little bit more advanced techniques for managing post-surgical patients with scleral lenses, and look beyond into potential refractive options that are currently available for patients who have irregular corneas that might benefit from surgery in addition to or in lieu of scleral lenses. So we're going to kick it off tonight with corneal transplants. And the main thing that most people want to know is when to refer a patient for a corneal transplant surgery, or if scleral lenses are going to benefit the patient more. Nowadays, we have a lot of technology available for us to fit a patient in a scleral lens, whereas in the past, it might have been more challenging if we had a very advanced keratoconus patient or a very irregular sclera. It might have been challenging to get these patients to see well out of a scleral lens. But we have quad-specific lens designs, freeform lens designs, corneal scleral ophthalmology, and impression-based fitting that's really going to allow us to fit patients in scleral lenses where in the past it might have been more challenging. So if you've been on a lot of scleral lens lectures with keratoconus, you've probably seen this study and you've probably heard this study. This was a study done back in 2018 at a hospital in Belgium that showed patients who had severe keratoconus, and this is K's greater than or equal to 70 diopters, they actually did pretty well with long-term scleral lens wear in that setting where they otherwise would have undergone corneal transplant surgery. So that's really great to see that patients who potentially would have gotten corneal transplants actually did really well with scleral lenses. A statistical report in 2016 showed us that in 20 years, it was predicted that 73% of grafts would actually fail. And that's a pretty astounding number to think about, especially if you are going to have a young patient have a corneal transplant. And at 30 years, 98% of corneal grafts were predicted to fail. So if we can delay patients as far into their life as possible for getting corneal transplants, it's going to be a lot better for them if they can have good vision with scleral lenses. Also, if patients were going to go down that route of getting corneal transplants, they're going to be on steroids long term. There's a lot more post-operative care that has to be done in these patients. If they are glaucoma suspects, being on a steroid, you're very worried that glaucoma is going to advance faster. So if we can avoid corneal transplants as long as possible, it's going to be healthier for the patient. Sometimes you might see a corneal opacity or a scar in the center of their vision, and you might think that a scleral lens isn't going to do anything. But actually, there's been studies that have shown that corneal opacities can actually regress and be reduced with pros or scleral lens wear. And you actually might even get good functional vision with a central scar. So at the end of the day, you always want to try a scleral lens first before sending a patient to get a corneal transplant. However, sometimes that's their only option. An indication or a couple indications for corneal transplants: limited visual potential with scleral lenses. Maybe they've been in scleral lenses for a really long time. They're just no longer able to tolerate the lens. They could be pretty advanced where they might need a corneal transplant. We'll talk about a case later on. But definitely you want to make sure that there's no active inflammation or infection going on or corneal edema, because that has to all be settled down before the patient should undergo a transplant. So I like to title my cases just to make it a little more fun. This case is near and dear to my heart because I've seen this patient on and on for the last year and a half, and I call this my hot girl summer case. So she's a 31-year-old Caucasian female, and she was referred to us for an acute corneal eye drops in the left eye. She definitely has those symptoms of severe blurry vision, light sensitivity, and tearing in the left eye. She already wears scleral lenses for keratoconus. Her right eye is seeing pretty well with scleral lenses. Left eye, she's not wearing one because of her eye drops. Her exam findings, typical eye drops exam findings on the left eye. So we're seeing a lot of edema, a lot of MCE, and we definitely see the Descemet breaks there. So she's definitely a very advanced keratoconus patient, very steep Ks, over 100. She was given conservative topical treatment with hyperosmotics, steroid, cycloplegic, and your pain medication because she was in a lot of pain. And we followed her. And after 5 days, she had no improvement in symptoms. And at that point, we just wanted her to feel better. So we gave her some comfort drops, which is just diluted proparacaine with artificial tears, and hope that, she could just heal with her topical therapy. But if it wasn't going to heal, we would potentially consider an amniotic membrane or SF6 sulfur hexafluoride intracameral injection to allow her to heal a little bit better. And we'll talk about that in a little bit. You can't put a BCL on because her Ks were so steep, it would just fall right off. So you can't do a BCL to help with pain. And we followed her for 5 weeks without any improvement on topical therapy. So we'll go back to the SF6 injection. There's a study that was done to show that SF6 could be a safe and effective therapy for the reduction of corneal edema in the patients with keratoconus and acute eye drops. It was 5 weeks, so we decided to go ahead and proceed with SF6. And unfortunately, after it was done, her air bubble was only present for 1 day. The air bubble is supposed to help tamponade the cornea so that it can heal on its own without edema continuously flowing or aqueous flowing in to cause more edema. But unfortunately, the bubble just didn't last. So she had to go back in and have a rebubble. And she was also a very anxious patient. So to get her to go in for a procedure just took a lot. And unfortunately, we had to do it twice. But luckily, the air bubble was present for 7 days. And then it finally dissipated, and she was able to heal a little bit better and return back to her optometrist to recheck her scleral lenses. So she was actually getting fit at the optometry school, and I knew her doctor pretty well. So we talked a lot about her case on the phone, and we decided that she shouldn't wear her left scleral lens for more than 4 hours because she still had some edema. It was improved, but it wasn't something that we wanted her to keep wearing her scleral lens for. So she was getting checked at the optometry school. Then she came back to us to resume the scleral lenses and just check to see how her vision was doing. Unfortunately, her best corrected vision was reduced, and now she has a central scar. So her vision was not functional. She's 31. She is very active out and about, so she can't see with that vision. And so now she's requiring a corneal transplant. A corneal transplant was performed without complications, and she was expected to go back into a scleral lens after the transplant. So things just keep getting worse. Unfortunately, she came in for her post-op visit month 4 and had an incidental finding of a epi defect right in the center of her graft, which looked very dendritic-like. So we were very concerned that she had an HSV infection. So we started her on Zergan and Valtrex, and she was on a steroid taper because she was only out a few months. But to balance her potential for graft rejection and the escalation of HSV, we really had to monitor her closely and decrease her steroid. So it was a dance around these two things that we had to look out for. So we were seeing her a lot, and then we got pretty close. Luckily, she healed, but now that dendrite became a epi defect a irregular healing haze, and it was right in the center of her vision. So in order to get rid of that, we had to bring her back in to scrape the surface cells. So we did a superficial keratectomy, one more procedure. Again, she was very anxious, so we had to do one more procedure. Luckily, the procedure was uneventful and she healed well. So she finally was ready for her scleral lens fitting for her left eye. And I talked to her optometrist on the phone, and we just decided it's best if I do her fitting so that we can just monitor her cornea with cornea specialists right there in case something happens. She definitely has a fragile eye. But she tells me, hey, we need to get this fitting done ASAP because I got to go to Vegas for a hot girl summer. And I said, yes, you do, because you've been coming to this office so much that you need to get out and go have fun. And we'll do your scleral lens fitting, and we'll try to get your left eye seeing well so you can have your hot girl summer. So let's talk about scleral lens fitting in a post-corneal transplant eye. So she still had sutures, and sometimes we wonder if we should fit a scleral lens when there's still sutures on. In this setting, yes, you can still fit a scleral lens with sutures, but the sutures have to be epithelialized, and you have to really watch those sutures because sometimes if they're exposed or the scleral lens is not vaulting over the sutures, then you get worried that you're going to cause them to be exposed, and then we have to prevent infection. So lots of things that you have to watch. The cornea specialist usually is going to refer the patient back when they feel like the patient's ready for their scleral lens. So communicating with the cornea specialist is important, and sutures tend to be removed, but they don't need to be removed. They tend to be removed at 12 months. And most of the time when they're removed, it's to just correct the astigmatism. So it's a strategic removal of the sutures. In her case, we knew she was going to go back into a scleral lens. So the sutures were just left on, and then she resumed her scleral lens wear at about post-op month 10. So the sutures may come out over the next few months, but we're just going to watch it. Concerns in corneal transplants, you definitely want to watch out for wound leaks, loose sutures, infection, and graft rejection. So signs of corneal graft rejection, these are important to look out for, and that includes corneal edema on the graft tissue, KPs on the graft tissue, so keratic precipitates, corneal vascularization, so you have to watch those closely. It's definitely better to take a photo of the eye instead of documenting. Definitely need to document what clock hour they're at, but photos are always great because you can just look at them and compare. You want to look out for any infiltrates. This reminded me of boards, the Codados line, the line of endothelial rejection. So that's something to look out for too. So those are the things that you want to make sure every time you see the patient, when you take off the lens, you have to look for all these things. What else can we do to optimize the corneal graft on a patient? The last thing you want to do when a patient has a corneal transplant and gets sent back for scleral lens fitting is to accelerate any graft rejection or have something wrong with the graft that's caused by the scleral lens. So that's like my worst fear. But you just have to pay attention to these things. You want to pay attention to the graft host junction. That host tissue is not as important, quote unquote, but that graft tissue is something that you have to preserve. Granted, you have to watch the whole cornea, but you want a high decay material so that there's a good amount of oxygen permeability going through the lens. Some proprietary designs like smart channels can really help promote tear exchange. This is an example of a smart channel right here, and great to take pictures so we can watch this vascularization here, and it's on the host tissue, so it's barely getting into the graft tissue. So it's something that we'll watch, but channels definitely are helpful in promoting tear exchange, reducing suction, and optimizing the health of a corneal graft. So backtrack to our hot girl summer. At post-op month 2 SLK and post-op month 10 SPPK, she was able to have her scleral lens fitting, and we made it. We sent her to Vegas for her hot girl summer, so she had a great time. So some tips for post-transplant scleral lens fitting. Definitely want to use an optic section and go over all parts of the cornea and the graft, really paying attention to those sutures. If you have anterior segment OCT, that's a great tool to use in an area of concern. You always want to remove the lens after they come in wearing the lens and stain the eye and check for any potential staining on the sutures, any loose sutures. You want to look for any graft rejection in white light and any corneal edema on the graft, as well as potential wound leaks or wound gapes. And that would be shown with fluorescein pooling. And you definitely want to do a Seidel test if you suspect any wound gaping. Okay, so that was corneal transplants. We're going to move on into our next topic of corneal cross-linking. And most of us are familiar with corneal cross-linking, but we'll just kind of review that when patients come in and have keratoconus, we definitely need to monitor them and make sure that they're not progressing. As soon as there's any progression, that's indication for corneal cross-linking. So it's important to establish care with a cornea specialist as soon as the patient is diagnosed with keratoconus. If we have the tools to monitor these patients, then that's great. But if we don't, then we should definitely refer them for posterior cornea tomography and progression monitoring. So these are the things to look for as far as progression goes. You definitely want to document these changes, and in the 24-month period, if there's any of these changes happening, then that's considered medically necessary for cross-linking for most insurances. Um, that includes an increase in steepest K greater than 1 diopter, greater than or equal to 1 diopter, an increase of 1 or more diopter cylinder in a manifest refraction, an increase of 0.5 diopter or more of spherical equivalent. And if there's no other information that you have, they said if you have a decrease of 0.1 or more millimeter in your back optic zone radius, which just means you're continuing to steepen your RGP, then that's considered progression. So it's really helpful to have documentation, because if you refer a patient to a corneal specialist and they're only seeing that patient for the first time, then they don't have any documentation to justify corneal cross-linking. So if you could send exam notes showing their current K values or their refraction, then at least that can immediately be shown that yes, they are progressing, they're qualified for cross-linking. So because sometimes the insurance may take a little bit of time, patients can potentially get fit before cross-linking or after cross-linking, and our timing with that can vary. If they're not cross-linked yet, you definitely want to fit a patient in a lens where they could potentially grow into the lens, aka make sure you have enough vaulting so that if they were to progress, then your cornea is not going to touch your lens. So if you're going to wait until they get cross-linked, when is the best time to fit the patient? There's no real consensus on when is the right time, but there's an article that kind of discussed about a month after cross-linking is the best time to fit a patient. And we just want to make sure that the epithelium is healed. Something else to consider is that the patient is going to be on postoperative drops for about a month. They're usually on a steroid taper. So by the time they get down to 2 drops a day, 1 in the morning, 1 at night, that's a good time to start wearing lens, because then they don't have to take their lens out and put their 3rd drop in the middle of the day. For existing scleral lens wearers, it can be as early as 2 to 3 weeks. Gloria Chu wrote a great article, blog post on when the optimal fitting for all types of lenses is after cross-linking. And for patients who have been in scleral lenses before cross-linking, they already know how to apply and remove their lens. So they can go in earlier. If you're doing a new fitting and the patient, you think they're going to have some application and removal problems, you're afraid they're going to scratch their cornea, you definitely want to wait longer and wait about a month before you fit them. We should be aware of what corneal changes can happen after cross-linking. So it's going to fluctuate. Usually what happens is your Ks are going to steepen at post-op month 1, and then it's going to flatten. And this was a post-FDA study of epi-off cross-linking that showed at about 1 month you see these changes, but then at month 3 to 24, so over 2 years, they can still continue to change over time. After cross-linking, corneas tend to flatten, so their vision may actually get better, but we never promise this to patients. It can happen. Actually, I had a patient that was 20/25 pre-cross-linking, definitely a keratoconus though, and then he became 20/20 after cross-linking, so he thought that it was a surgery or procedure that helped him see better, but luckily his cornea just flattened a little bit. So for cross-linking, I have a case here that I can share with you, and I call this the rush fitting because this was probably the fastest scleral lens fitting I've done. And he is a 15-year-old male. He was referred to our clinic for cross-linking. His optometrist didn't fit scleral lenses, so I was going to fit his lenses after. He came in seeing 2800 and 2400, and he doesn't even wear glasses, so he's probably just squinting his way through life. He plays baseball and he wrestles, so he doesn't really think he has a problem with his vision, but he's definitely going to need something to see better. I can't just let him go with this vision not fitting him in a contact lens. So patient had all the medical necessity documentation to get cross-linking, and he was scheduled for his right eye first in about 2 months from when he was originally seen, and then 4 months for the left eye. So these are his pentacams. Definitely has keratoconus there. And he came back after a month from his right eye cross-linking and saw me for a scleral fitting. And he actually said his vision improved. So he he jumped to 2250 in that right eye. And I put on scleral lenses, showed him his vision with my diagnostic lens, got him a 2025 in the right eye and 2030 in the left eye. And he was just amazed with his vision. So he definitely wanted lenses in both eyes. And I had a discussion with him and his mom. And I said, I can fit you in both eyes. So your right eye's ready. Your left eye's coming up in about 2 to 3 months. I can fit you, but we're going to have to take a 3-week break after you do your cross-linking on your left eye. So if you're motivated and you want to come in and do everything, come into the follow-ups, then we can do it. So he was really motivated, and he was actually very good at application removal. He got it on his first try, and he did really well. So given the vision, his mom and him decided to proceed with the fitting, knowing that they were going to have to take a 2 to 3 week pause after the left eye. I rush ordered the lenses, worked with my lab. He was able to wear both lenses until his left eye. And you can wear your scleral lens up until the day before cross-linking because it doesn't affect anything. So he wore it up until the day before. And then I shortened my follow-ups to 1 week. And that way I stayed in my warranty period. And now he can see with his scleral lenses. I told him we were going to tweak the left eye probably after his procedure. So I think I made a couple of changes, and then these were his final lenses. Okay, so we're going to jump to cataract surgery now. Believe it or not, patients are going to get cataracts even if they wear scleral lenses, unfortunately. And sometimes they're going to get to a point where you can't determine whether their vision is limited by the cornea or the cataract. And that's when I like to do a scleral lens overfraction to rule out the cornea pretty much. And something else that I've been doing in these moderate cataract patients is just doing a scleral lens overfraction and then doing a bat with that scleral lens and see if it drops their vision. And if it does, then I know that's the cataract. And if their vision is the same, then I know it's probably cornea. So this is a case, I call him the cornea versus cataract because it's a mystery we'll just have to solve. He's a 66-year-old male. He has keratoconus. He was referred by one of our optometrists that we work with for cataract surgery or scleral lenses. So she talked to me and she said, I'm not really sure. I think it's cataracts, but can you take a look and possibly fit him in a scleral in the left eye because he's wearing one in the right only. He does have cataracts, and his right eye actually was visually significant, but his corneal status was just not good, and I'll show you in the next slide. He did have a transplant in the right eye back in 1995, and he is diabetic. So he came in wearing a scleral lens in the right eye. He was seen about 20/50, and then the left eye, he didn't have a scleral lens on. He said he could never wear one. It just was never comfortable for him. He never got good vision out of his left eye. This is his right eye. So a lot of vascularization there, and he does have cataracts. So not really sure what is limiting his vision. Probably a little bit of both. And this is his left eye. So he does have an apical scar. He's got some steep Ks and clearly keratoconus and cataracts. So he said he was wearing his right eye, but doesn't wear one on the left. We proceeded to just try scleral lenses first before cataract surgery because the cataract on the right eye was actually more significant than the one on the left eye, but we definitely don't want to touch the right eye with anything given that corneal status. We want to improve the cornea first. So he was actually given a steroid and antibiotic and potentially consider an antiviral if that was not getting better. And I try to refit him in both eyes because his scleral lens on his right eye was just not optimal. It was too small for him and it was bearing on the cornea, which was just not good. So I fit him into a larger diameter lens in both eyes. I made his lenses have high decay in the right eye with channels, and kept him at 20/50 in the right eye, but a little bit healthier fit. And then the left eye improved from 2800 to 2060. So that was pretty good in my book, but he actually didn't think it was adequate enough. And he was also having some application removal difficulties because I made him wear a much larger lens, and he wasn't really motivated. But I told him, I said, this is your vision, your left eye, I'm getting you to 20/60, but if it's still not good enough for you, then we have to consider cataract surgery or potentially corneal transplant. So patient was referred back for potentially corneal transplant. If you want to optimize the patient's refractive outcome in this case, then it might be better for him to have a corneal transplant because he wasn't able to tolerate a scleral lens. So even if he had cataract surgery, he still has to go into a scleral lens. So at least if he got a corneal transplant, then he could potentially have a better refractive outcome after the sutures are removed, which would probably take about a year. Then he could have cataract surgery and really optimize his vision. So we'll see what happens, but that's the plan. Okay, so now if they're gonna have cataract surgery, what kind of IOL are we gonna use? We have so many scleral lens options and we have so many cataract IOL options. There's just so many combinations to pick from. A lot of discussion on whether patients should benefit from a toric IOL versus a monofocal IOL. So I think if a patient can be refracted to about 20/50 or better, and they get functional vision, then a toric IOL actually might be an option for them. However, if we're going to do that and they're going to wear a scleral lens after, then they're going to need a front toric. So you're just going to make it harder for yourself if you're going to fit them in a toric scleral lens after. But it can be done. If the patient for sure is going back into scleral lenses, that they're going to have cataract surgery, but they need a scleral after, then you most likely should stick with a monofocal IOL. Makes your fitting a little bit easier, especially if they're just going to go back in and wear it all day. So there's a lot of lenses out there. We have extended depth of focus lenses, we have light adjustable lenses, and we have multifocal lenses. I would avoid multifocal lenses on any irregular cornea, but a light adjustable lens might be an option for patients who have astigmatism that is a little bit harder to achieve with the toric IOL. But if those patients come back to you and then you need to fit them in a scleral lens, should know that there was probably astigmatism correction in that lens, and you'll probably still need a toric scleral lens. How soon can we fit patients in scleral lenses after cataract surgery? Well, the corneal incision from cataract surgery actually heals really quickly. You probably want to wait at least 2 weeks if they were existing wearers. Also, they're going to be on drops for a month again, so waiting till they're down to 2 times a day is a good idea. And you want to avoid suction just to be nice to that corneal incision. And if you're going to wait, or if the patient hasn't had scleral lenses before, probably best to wait about a month after. Again, no huge consensus, but just what I think. Okay, so this is my case called the triple toric. And he's a 75-year-old male referred for corneal evaluation last year. He has probably had the most refractive procedures ever. He had RK in 1976, then he had PRK, then he had LASIK, don't know when, and then he had cataract surgery in 2013. He was a police chief, so he had to be out of glasses and contacts to do his job. So he had a lot of refractive surgeries. Of note, he also had double vision after he had cataract surgery. So he had strabismus surgery to correct his horizontal diplopia, which resulted in vertical diplopia, and had another surgery to correct his diplopia. But luckily, his diplopia is corrected. And when he came in, he wasn't having any double vision. So he didn't have to deal with that. He also has glaucoma. So his goal is just to see well while he plays golf and so that he can drive and pass the DMV test. Luckily, he sees 20/40 uncorrected, so that's actually pretty good. When I refracted him, spherical equivalent of plano, so really can't improve his vision with glasses, unfortunately. This is his exam findings. He has RK. He did have LASIK. There is a LASIK flap there, and a little bit of haze in each eye. Had this interesting epithelial plug on an RK incision, so watching that. Oh, and he has toric IOLs, so they're sitting nicely at 180 degrees. So 20/40, I'm actually really surprised he's seeing that well, which is pretty good. He was sent to me for an RGP overfraction. This was his first visit, and so I saw him last year, and I got him to 20/30, 20/25 with RGPs, but he doesn't want to wear contact lenses. So he was super not motivated. And he's like, I want a surgical option. I don't want contacts. So I just did an overfraction to see what his visual potential was. Then I sent him back and to one of our surgeons, and talked about potential surgical options, maybe topography guided PRK to help normalize his cornea a little bit more. So let's talk about refractive surgery versus scleral lenses. So topography guided PRK is a ablation technique that can create a more ideal normal corneal curvature. And you have excimer laser spots that flatten steeper portions and steepen the flatter portions by actually flattening the flatter portions around the area. So it attempts to normalize the cornea into a more prolate shape. And we'll talk about candidacy and epithelium in a bit, but I'll go back to him. We tried to get scans to see if topography guided PRK was even an option for him. The thing that we need to have is to have consistent mapping of his cornea, because if you have a steep area in one image that isn't there in the other image, then we don't know if it's really there. So you have to take a bunch of images and compare image 1 to 2, 2 to 3, 1 to 3, and make sure that they're all consistent before we can even entertain a potential topography guided treatment that can reduce higher order aberrations and irregular astigmatism. Unfortunately, we didn't get good scans, so we had a discussion with him and we told him, let's not do surgery because we could increase potentially your irregular astigmatism, and you definitely don't want that. So he left with his 20/40 vision, and he just had to accept that he couldn't have surgery. But he came back. He came back on his own 8 months later, wanting an option. And he said, Doc, what do you got for me? And I said, scleral lenses. So we fit him in scleral lenses, and I fit him with a toric back surface to stabilize his lens. And I knew I was going to need a front toric to correct his lenticular sill. So I did a front toric, a back toric, and he had a toric IOL, and he managed to get 20/25 plus 2, 20/25 minus 2 vision, but now he can pass the DMV test and play golf. So he did great. All right, this is my next case. I call him the scleral believer. He wasn't a believer in sclerals, kind of like case 4, but he was interesting. So I'll tell you the story in a bit. But he had hyperopic LASIK back in the day. And then he had a raindrop corneal inlay removal on his left eye. So the raindrop corneal inlay was attempt to treat presbyopia in the non-dominant eye, but unfortunately the inlay caused some haze, so it had to be explanted, and it left him with this corneal topography where there's a interesting shape of a circle that's a little bit steeper around here, and his vision is 20/70 uncorrected and best corrected to 20/50. So he also wants a surgical option to improve his vision, and he also doesn't want to wear any contact lens. So we attempted to get some scans, but we found out that his epithelium is a little bit irregular, which can make topography guided treatments more unpredictable as far as their healing process. So that was discussed with him. He also had a lot of dry eye, so we put him on autologous serum tears and Procara, reassessed to see if we can get consistent imaging. So he was actually scheduled for topography guided PRK to reduce his higher order aberrations, and he eventually got good scans, but on the day of surgery, we just threw it out there one more time and asked him, do you want to try a special contact lens that might help correct all of this? And he said, well, let's just try it. So it was the day of surgery, and I put on a scleral, and he actually saw really well at near because he had this multifocal effect from his cornea. So he was a 61-year-old phakic patient that saw 20/20 at near. He saw a lot better at distance, but it wasn't the best. It was still better than 20/50. So he was really happy with his vision, and he loves his scleral lens. He loves it so much that he found out that we had our academy conference in San Diego, and he lives in San Diego, and his scleral lens had broke. So he went up to the booth at Academy, to that scleral lens company, and told them that he wears that scleral lens and asked for a replacement. So it was really funny, but he loves his scleral lens because he wears it every day. And that's him with his scleral. Okay, so what kind of options do we have for patients with irregular astigmatism or keratoconus? Are there any refractive options? Well, we talked about topography guided PRK to reduce irregular astigmatism, but it doesn't necessarily improve their uncorrected vision. It can reduce the HOAs. Also, it's considered off-label in the US, so has to be proceeded with extra caution, only after taking into consideration many factors. Anytime you're going to do refractive laser surgery on an eye, you are putting it at risk for more ectasia. So definitely don't do this often in our clinic, but it is an option, and the risk usually outweighs the benefits. But we have lens-based procedures that can actually correct vision, myopia, and regular astigmatism up to about 4 diopters. And this is a procedure where you're not touching or ablating the cornea at all. And indications for this procedure is age 21 to 45 with an anterior chamber depth of at least 3 millimeters. This was FDA approved in 2022. So this patient here, she actually is a good example of how she could benefit from a refractive procedure. I call her the non-wetting lens just because I had a really tough time with her lens wetting, which we'll see later. But she's a 40-year-old female. She was referred to us for cross-linking and scleral lenses, and she has high myopia. So she's a -16 with SIL, but she's wearing soft lenses because she can actually see pretty well. She can see 20/50 with her soft lenses. And these are her topography. So she clearly has keratoconus. But she has pretty nice anterior chamber depth. So she is greater than 3, which is good to know. Keep that in our back pocket. And unfortunately, she was referred to us for ICL in 2020. So 2 years prior, she was referred for ICL, and all we had was her refraction. So we didn't have a topography, and we had her best corrected vision. You can definitely see that that has increased largely in the last 2 years, and her best corrected vision even decreased. So she's clearly a progressing keratoconic patient, but she never showed up to her consult. So we weren't able to get a tomography to even see what she looked like. But we ended up fitting her. I ended up fitting her with scleral lenses, and we need to get her cross-linked ASAP, and because of her progression. This is what I was talking about earlier. You definitely want to not do this on a patient that hasn't been cross-linked yet. So leave room for the eye to grow into the lens. Need to monitor her progression. So after all this, after she gets cross-linked in both eyes, if she's refractively stable, then she actually is a good candidate for ICL. The question is, though, are we going to do a spherical ICL? Are we going to do toric ICL? Depends. There's no right or wrong answer. If she was functioning okay with her toric soft contact lenses, getting her to 20/50 with that, then that might be an option for her, so she doesn't have to wear her sclerals all the time to just see decently and functionally. So she might benefit from a toric ICL. But if she's going to want her best vision the way she sees out of her scleral lenses, and she's going to continue wearing scleral lenses, then a spherical ICL would actually be better for her, because then it's a little bit easier to fit her sclerals after. This is her non-wetting lens. Little Hydropeg fixed it, but I just thought that was insane how non-wetting it was. Okay, final thoughts. Definitely always want to try a scleral lens first. At minimum, get a scleral or RGP over-refraction just to determine what their vision could be. And you want to rule out whether the vision is going to be limited by the cornea or the lens. So a scleral over-refraction can definitely help you. If you even think that they're considering to wear scleral lenses, then I do a scleral over refraction, and that way I can do a fitting at the same time. And if they come back and they're like, actually, that lens was really great, can you order me the lens? Then I already have everything I need to know. Things to take into consideration: patients' visual demands. Are they trying to drive? Are they just trying to pass a DMV test? You just want to give them that type of vision. Or are they trying to play golf and see really, really well? What's their lifestyle like? How's their dexterity and their motor skills? Are they going to be able to put their lenses in and out day to day? Do they have help at home if they don't? Are they going to be compliant? Are they someone who can clean their lenses and take care of their lenses? And if you are going to move into a surgical procedure for them, especially a refractive one, you need to make sure that they have corneal stability. Are they cross-linked? And refractive stability.